Hello, everyone. Good morning and welcome to CME Palooza Fall 2022. My name is Derek Warnick, one of the co-producers of CME Palooza, along with Scott Kober. And thank you for joining all of us this crisp and chilly October morning, at least it is here in Philadelphia, 36 degrees this morning. I had to put on my coat to take out the dog. The dog was not impressed with the weather, but we're warming up soon. We have a full day of sessions scheduled for you today. Some really great sessions. Hope that you can join us for as many of those as possible. But kicking off our day today is our breakfast session sponsored by Med Learning Group, Healthy Futures, the intersection of public health and CME. Moderator for this session is Lauren Welch, who is Vice President of Outcomes and Accreditation at Med Learning Group. But before I turn things over to Lauren, of course, every CME Palooza session, we begin by a big thank you to all of our sponsors. Our gold sponsors, Daiichi Sankyo, Med Learning Group, of course, and PER. Our silver sponsors, ACHL, Academic CME, Antidote Education Company, Catamount Medical Education, DKB Med, Hippocrates, Helio CME, Medscape Education, Integrity CE, Platform Q Health Education, Prova Education, Red Med Ed, Vindico Medical Education, Platform Q Health. Oops, I got lost already. Platform Q Health Education, Prova Education, Red Med Ed, Vindico Medical Education. Now I switch pages for our bronze sponsors. Answers in CME, XDev, Bonum Continuing Education, Creative Educational Concepts, CMEology, Excalibur Medical Education, Global Education Group, Infograph Ed, MedIQ. Last slide. PACE, Paradigm Medical Communications, Postgraduate Institute for Medicine, PriMed, PVI, RMEI Medical Education, and Right Medicine. As always, there are three ways that you can ask questions at CME Palooza. You can use the CME Outfitters text line. Thank you to them for sponsoring. 267-6660-CME. You can tweet your questions using the CME Palooza hashtag. And you can use a YouTube chat function. If you click on the little watch on YouTube icon in the lower left corner, you can enter your questions that way. Personally, I think that's sort of an underrated way to do it. But you can feel free to use any of those that you want. I'll be monitoring all of those and feeding your questions to the panel. We will be using Poll Everywhere. For most of our sessions, we'll be using it early on in this one, so go ahead and get yourself ready. I think we're using it for almost every session, maybe one in the afternoon. We are not, Poll Everywhere is our honest response system. Big thanks to Broadcast Beat Studios, who is sponsoring that this year. You can either download the Poll Everywhere app and enter CME Palooza 005, or you can just simply type in the URL into your browser, pollev.com/CME Palooza 005, and then just leave it open. It's the easiest way to do it. Like I said, we'll be using it for most of our sessions today. And last slide from me, any opinions, discussions, and or conclusions expressed are those of our panelists and do not represent an endorsement by or a position of their employer, its parent company, or affiliates. And with that, I am going to turn things over to Lauren.
Thanks, Derek. And thank you everyone for joining the first session of the day, bright and early. And a big thank you, expressing our gratitude to the CME Palooza organizers. It's such a wonderful, easy to access forum for everybody. We are gonna kick our session off on the intersection of public health and CME with some polling questions. So if we want to pull those up and just get some of your thoughts on this, if you've had time to get it in your browser. First off, please rank your confidence in defining public health. So it looks like I have a general idea, which is probably what I would say as well, prior to working with these experts. Great. All right. All right. Next one is, do you think continuing education has a role in public health? Okay. The great majority say significant role. Looking good. All right, about 80%. Okay, great. Well, thank you. That's informative going into this presentation. Before we dig into the content, maybe all the panelists could just quickly introduce themselves. I'm Lauren Welch, the VP of Outcomes and Accreditation at Med Learning Group. I've been there for about 8-9 years now.
My name is Helene Beluni. I am the Associate Director of Strategic Partnerships at Med Learning Group, and I just hit my 4-year anniversary this month, actually.
Happy anniversary, Helene.
Thank you.
My name is Nicole Longo, and I am the Director of Medical and Scientific Services at Med Learning Group, and I am approaching my 4-year anniversary November 1st.
Well, happy anniversary, Nicole. And my name's Samantha Lansdowne. I'm with Regeneron Pharmaceuticals. I'm our Director of Educational Strategy in the Ophthalmology TA, and happy to be joining you all this morning.
Yes, and thanks, Sam, for joining us. We feel very glad to have you here to provide the supporter perspective. We have a case study that we worked on together that we'll dig in a little more as we get through it. But if we want to go to that first slide, I'll just kind of lay out the goal of today and then pass it on to Helene, who's actually about to get her master's in public health and is much more of an expert in this than I am. But just to lay out our goals on the next slide, we'll really be looking during this presentation at how CME, CE in general really does address public health in a lot of ways, and how we could do more, how we could really use our programming to pull out some of the social determinants of health and how to optimize health outcomes and work with our healthcare providers to not only educate them on the clinical data, but also the wider public health ramifications and things to think about with their patients in every therapeutic area. So with that, I will turn it over to you, Helene, to sort of go through some exercises looking at what public health is, how it relates to CME, and what we could be doing more. And then Nicole will be looking at a program that sort of serves as a case study of that in ophthalmology. And Sam will be sharing the supporter perspective about why this is important to support. And, we'll try to make this as interactive as possible. So everyone can chime in as each other's talking, and I'll be keeping an eye on the chat for questions.
Thank you, Lauren. Derek, if you don't mind switching over to the next slide, let's dive in. And I promised to not bore you guys at 9 o'clock in the morning with a bunch of definitions, so we're not going to do that. Instead, we're going to pick apart this photo together. I'd like for everyone to sort of shift their frame of mind to a more public health thought process for at least the next few minutes. Equity is one of those terms that gets tossed around all the time, but sometimes it's not something that we actually can see in action. And I love this photo. Many of you might have seen it floating around over the past few years. So let's dive in. Let's talk about these people trying to catch a baseball game. So if you look at the first photo, you'll see 3 individuals trying to peek over the fence to watch this baseball game. And, you can look at it and say everyone's standing on a box to try to, peek over the fence. And over here, you could see that everyone's being treated equally. Everyone has one box to stand on to see over the fence. However, it doesn't really look like, their individual needs are being met here. The fence is probably, standard fence, 5 feet tall. Looks like that first guy could probably see over the fence without the box. And in the second photo, you could actually see that's true. And we can dive over into the next photo here, and you'll see that we nailed it with the second individual. They only needed 1 box, and we did good there. And then that third person really needed 2 boxes. So in the second photo, we're addressing everyone's needs to get to where they need to be to see over this fence and watch the baseball game. And the second photo is actually what equity is. It's providing everyone with the resources that they need, looking at their individual characteristics to get to where they need to be their best. And in the last photo, we see that they swapped out this yucky old fence for a new fence. And it's a fence that everyone can see through, and they don't need boxes to see the baseball game. But public health usually will dive in a little further. We want to know why these people aren't at the game with everybody else. How did they get behind this fence to watch this game? Maybe they can't afford tickets. Maybe they don't know how to buy tickets. And then we want to look at, is this fence really a barrier for them, or was it meant for protection? And usually at any baseball game, you're going to see a fence or a net or something that's going to make sure nobody gets knocked in the head with a baseball. So certainly we look at, that fence was meant for protection, but for some people it does act as a barrier. So we can translate these thoughts to, why didn't they get tickets, to why aren't these people getting the care that they need? And, as this fence, is a barrier and protection, what healthcare policies have been implemented for protections, but can also be seen as barriers for many other people. And that's something to keep in mind, because public health is really, how do we do the most good for the most amount of people without doing any harm to others? And unfortunately, not everyone fits into that mold. Public health is not a one size fits all. On a good day, it's a one size fits most. And all those people that don't fit into that mold still need attention, still need love, still need resources. And how do we get them that? And Derek, if you don't mind going into the next slide. So now that we know what equity looks like, let's look at what inequities look like and what they do. So these inequities that we see, mostly socioeconomic inequities, which were also, they fall into the category of what social determinants of health are. Those inequities really result in health disparities. And health disparities is also one of those words that get tossed around all the time. So health disparities are essentially a direct byproduct of unfairly distributed social and economic factors that shape everyone's lives. And that's exactly what social determinants of health are. They're, the conditions of everyone's environment. Where were you born? Where do you live? Where do you work? What do you do after work? Do you worship? All of these things really impact your quality of life, your behaviors, your level of comprehension and understanding, and your access to care and resources to get what you need. So you can dive in, and social determinants of health are often grouped into just 5 categories, which would be economic stability, your physical environment, your education, your social settings, and then of course the healthcare system that you're surrounded by. But this image I love because they actually throw food in here, and food is huge. You are what you eat, and how you fuel your body is exceptionally important. And sometimes there's people who don't have access to food at all, and sometimes there's people that don't have access to healthy foods, and that really impacts the care, your care plan and how you can stick to it. And I also threw in demographic characteristics here for social determinants of health, which would include sex and gender, your sexual orientation and how you define yourself, your ethnicity and your race. And I throw that in there, and that spans across everything. So I love that it hits every category here of social determinants of health. And so health equity essentially is the absence of these inequities. It's the absence of health disparities. And that's where we want to get. The absence of health disparities are certainly preventable. And we call them that, we say that they're unfair because they're really systemic and they're very avoidable with the right planning. And that's what we want to dive into. How do we start planning this a little better? And where does CME fit into this planning? And how do we shape public health? And how does public health shape us, and vice versa?
Helene, I'd love to
Yes.
point out from a clinician perspective, I'm really happy that you included food in here, because you have a lot of patients, especially those that are in minority populations or underserved populations or even elderly populations, where they have limited access to resources and they may have to choose between food and their medication. And that's an important thing to recognize, especially as a clinician, how that affects what your treatment could be.
Absolutely. Thank you. Derek, I think we can go over to the next slide. So I want to dive into one of the most popular public health frameworks that's been introduced. So this actually is all the 10 essential public health services. And this cycle really lays the foundation for just continuous health promotion and protection for all communities, from people from all walks of life. And this actually was first introduced in 1994. And the center of the cycle was actually research. And it took 25 years for them to revamp this, and it was just released in September of 2020. And equity was finally the center of this, and that makes much more sense. It defines what public health is today and what we hope for public health to see moving forward. And so this framework is going to have 10 steps, and of course it's a cycle. You're going to start with assessment, and then you're going to switch over to policy development and then assurance for maintenance. But you can go back and forth, and each institute, like this cycle really has a place in, every organization. It could be healthcare systems. You're going to look at state and government associations, the CDC, the World Health Organization, and also state and local departments of health. And these are steps that everyone can take to make sure that their communities that they serve achieve health equity. And if we go into the next slide, Derek, we can see that there's quite a few that really suit us in our industry and stuff that we already do. So we can look at the first one, which was assessing and monitoring population health status and factors that influence health, et cetera. This we 1000% already do in our industry. When we are probing and doing all our research for our needs assessment, that's exactly that. And our outcomes also play a huge role in this step as well. And then if you look at number 2, which is over in the policy development area, that's communicating effectively to inform and educate people. That's our bread and butter. We do this every day. This is exactly what we do. This is our industry. And now that we can see that this is directly tied to a public health process, we can move better in this. We can move with a little bit more intent. And then the last one is build and support a diverse and skilled public health workforce. And that is going to be huge for us, because now that we know that we have a fit in public health, and public health certainly supports our industry, we can start building this workforce. And that workforce is going to be us, our colleagues, our team members, but also the healthcare providers that we educate. And in making sure that our programs have this content is going to be vital. And Derek, we can dive into the next slide. Thank you. So another huge framework is called the Healthy People Initiative. And this was actually established back in 1980. And the 1990s is when it first, we got our first data set out of this. So Healthy People is an all-inclusive nationwide agenda for health promotion and disease prevention. And it was created by the Department of Health and Human Services and their Office of Disease Prevention and Health Promotion. So each of these, they're going to dive into, what areas of public health really need some TLC, and how do we do that in the next decade? So in 1980, they looked at, okay, what parameters do we need to hit by 1990? And then 1990, they looked at, okay, what's the next steps that we need to do? What do we need to look at and hit by, the year 2000? So the first year it came out, it seemed to be pretty basic, and that's normal. It's a brand new, initiative. And they focused on decreasing death and increasing lifespan. And then they worked on, increasing independence among the older population, which is wonderful and super important. And then Healthy People 2000, they added a little bit to that. They wanted to increase the span of healthy life. And this is where they introduced reducing health disparities. And, when you look at this timeline, it's a little funny to me because at the time, health disparities was not properly defined. The word disparity just means a difference, a variation. And they kept it really broad there. It just meant that there's something different within this population, but they didn't define what that really meant. And then they also wanted to achieve access to preventative services for all. So they're getting there, but they're not quite there yet. And then Healthy People 2010 expanded on Healthy People 2000. And then they switched over from reducing health disparities to working to eliminate them within the next decade. Healthy People 2020 was a pivotal moment for public health. It's when things, really started to click. And the Affordable Care Act was introduced in 2010 as well. So, and that really focused on more preventative care, and it switched over, our healthcare system to a more proactive approach as opposed to reactive. And in 2020, or actually in 2010 for Healthy People 2020, it's when they finally, really defined what health disparities are. And that was huge for us. So in this Healthy People 2020, they focused on disease prevention and attaining high quality, longer lives free of preventable diseases. And they wanted to achieve health equity here and eliminate disparities for all groups of people. And that includes very vulnerable populations as well. And of course, we'll always focus on our vulnerable groups, but it's still important to include everyone here. And they also wanted to promote healthy development and behaviors and choices. They wanted to change people's outlook on, the choices that they make. And that's directly tied to social determinants of health and helping people identify what that means and what social determinants of health really frame, their access to care and their adherence to their care plan. So we can dive into the next slide. So the next slide is actually going to go into Healthy People 2030. So Healthy People 2030 was kicked off in 2020. So we're now 2 years in. And this one is much more detailed and thorough. The framework actually explains the foundational principles much more clearly. The overarching goals are more expansive. They introduced a detailed plan of action and a history for why these plans of action exist. And one of their objectives here, as you can see, is they want to engage leadership and key constituents and the public health across multiple sectors to take action. So here they really want to expand the reach of public health. And that's exactly what we want to do. We want to help support that initiative. And by, bringing public health into our world and really embodying that moving forward. So they introduced a vision and a mission, and providing those two things really help people, that will really resonate with people, and they really can understand, where they align. And it's always important when you're partnering with anyone, you want to support their mission and you want to see their vision and make sure your visions align. And in order to help that, they actually included new indicators to track progress along the way. Previously, you'd have to wait for these big, massive reports to come out, but this time it's a little different. So within their overarching goals, there's actually 358 core measurable outcomes. And that sounds like a lot, and it certainly is. But these are actually going to be very disease specific. And then when you look at the disease specific components, they're actually going to be further grouped into what you see on the bottom here. So it's going to be health conditions, health behaviors. They're going to focus on populations that need a little bit of love. That could be the LGBTQ community, elderly populations, the youth, what affects them. You can also look at this from a settings and systems perspective. And then one of their main focuses here is social determinants of health, and that is absolutely huge. So these indicators over on the right-hand side are going to be great. So you can log into Healthy People 2030 and check how things are doing along the way. And they can see, we're kind of still at our baseline, we're improving a little bit, or things are getting worse. So that's how we can gauge where we need to, gauge our attention and put our attention to as we continue on through the decade. And hopefully we hit these goals by 2030. So I also want to look at here how medical education is evolving outside of the continuing education industry. And historically, I love this quote at the top, and it was like, the changing landscape and evolution of medical field has been significantly influenced by the improvements in health attributed to advancements made in the public health field. And you want to look at that, because there's so many components of medical education. So it's, let's look at, the MCAT is changing. Historically, that was just, a lot of math questions. Nicole, you could speak to that more than me, but I don't believe in previous years it didn't include the, behavioral and social sciences, if I'm correct.
It was math and reading and a fingerprint.
Yeah. So they're changing that a little bit more, which is huge. So they're actually implementing, they're going to highlight the interplay between health and society. And that's huge because that is literally nails right on the head to what social determinants of health are. And they're also correlating medicine with public health perspectives, which is huge. So for example, nutrition and how nutrition ties to health issues. And that goes back to, that second slide where food is super important here. And then, these changes are going to be happening big and small. There's going to be some things that we haven't heard about. So I want to introduce to you, it's called MedEd Cloud. Dr. Raji Akila, who was a former med student. He was a physician working in pediatric oncology and saw all the, where medical education throughout his learning in medical school and his residency and fellowship kind of fell short. And he realized that, in medical education, while you're studying to get your degree, you're honing in on the medicine, and there's a huge gap between what's actually happening in the world. And so he wants to take a more holistic approach to medical education, and he created this platform, and he has full support from Global Health Impact Network, which is also a group of physicians who believe in his mission and want to support that. And so they're actually working collaboratively with key decision makers to implement legislative changes in medical school curriculum and residency and fellowship programs. And one of the things that they've done so far is implement nutrition programs. And there's a huge gap between what physicians know and clinicians know about nutrition. And, certainly that's why we have nutritionists and we love them, and they all will always have a place here. That's their specialty. But sometimes you'll see, you meet with your nutritionist and then your physician might not be fully aware of what they said. So how can we really support that across the continuum of care and make sure that there's no gaps there? So that's what he's doing. And he actually is also providing resources for the new MCAT on his platform as well, which is going to be wonderful. And then lastly, one of these, bigger initiatives that we might hear about was the Office of Minority Health. And they're actually launching a cultural and linguistic competency initiative. And they implemented national standards for culturally and linguistically appropriate services called CLAS. And that's going to be spanning across all of health and all of healthcare. And they have online CE programs at the moment. And their website is called Think Cultural Health. And they have programs surrounding maternal and behavioral health and how to approach your patient active cultural perspective.
And Helene, just to jump in, because we did get a question as to whether we partner with public health professionals and programming or needs assessments. And this slide just reminded me of, we'll be getting into a case study in a little bit where we have partnered with the Office of Minority Health on validating some of our content when it comes to disparities in care in ophthalmology, and also for some of our COVID frontline programming. So we found that, some of these organizations such as OMH are very willing to review and make sure that the language we're using is the language we should be using in our programming, as we're not experts in this ourselves.
Of course, health literacy is a huge factor here, and that ties to people's, ethnic background and their education. Again, a social determinant of health. So it really all links together. And because medical education evolving, Derek, if you don't mind going over to the next slide, medical education is evolving into, it's evolving outside of our industry. So it's important for us to, make this change within our industry as well to support what's going on outside and make sure we really all operate on a unified front. And so how do we do that? So, for example, what our organization is doing, we're certainly enriching our communities of care platforms. And our communities of care platform is a website launched for a specific disease state, and it has so many resources available for both clinician and patient. And we're introducing multiple language translations, and we're also providing more of a patient perspective. We have a lot of patient podcasts, and we also we introduced what we call patient journeys. So it's interactive. You can click on it and, it guides you through this pathway of what a patient might, go through with asthma, for example, all the, the treatments you might hit along the way, how they might impact you, what questions you might want to ask your doctor, what questions your doctor might ask you, and what your treatment options are going to be along the way. And then we're also enhancing our provider and patient toolkits as well. So we'll partner with many organizations such as patient advocacy groups, which is going to dive into our next component where we are, investing in more strategic partnerships. They're able to provide us a lot of resources where we can support what they're doing, and also provide clinicians, a little bit more awareness of, these certain advocacy groups and the resources that they have that they can then extend to their patients. And there's certainly strength in numbers in everything that we do. So strategic partnerships are so valuable. And we've also, in addition to patient advocacy groups, we've partnered with government entities, as Lauren said, with the Office of Minority Health, and as well as the Public Health Foundation to share a lot of our programming. And then we've also partnered with some multicultural provider organizations. And that's super huge here because these groups will often treat patients of their own ethnic background, their own race. That's been a huge factor in, where patients feel comfortable the most. It's really someone that they can, see themselves in, and they feel really comfortable talking to them, and they might listen to them a little better when it comes to, their care plan, which is, so great. I mean, take my dad, for example. The man doesn't listen to anybody, but he found a Lebanese doctor and now he's doing all right. And then we also are elevating our outcomes and our needs assessment. And that's going to be super vital, especially from our supporters' perspective. We want to dive into much deeper into analyzing incidence and prevalence rates, of course, morbidity and mortality and where they stand. And now we're going to dive into why these rates exist. And we're going to be creating new public health learning objectives that are going to be able to provide us measurable outcomes. And that's crucial here because you don't want to just, touch upon these things within your content. We really want to measure how we're doing here. So if we're not able to see that the change is happening, then the change really isn't happening. And so we can do this because we can utilize Healthy People 2030 as a roadmap. It's going to be a 10-year roadmap, and we can use the essential public health services as our guide. We can see that we already hit some of those 10 steps, and now we can probably hit a little more. And even if we can't hit them within our own organizations, our partners that we invest in certainly can. And we can all work together to do this. And that's going to help us support diversity and equity inclusion, including that in all of our programming moving forward. And we can look at that from, Med Learning Group is a hub for Project ECHO, which is extension for community healthcare outcomes. And that was created by the University of New Mexico, I believe. And that was essentially created to bridge the gap between the resources and access that rural communities don't have and what big metropolitan areas do have. So these clinicians can get together, talk about this specific disease that we're talking about, and share best practices or things that they've seen, which is super helpful. And we still do our Grand Round programs. And although they've taken a hit since COVID and they're more virtual now, that group dynamic is still super essential, especially to public health, in addressing systemic issues that these clinicians might see together within their own communities. They can, take our course, and then they might sit together for a few minutes and kind of think about what obstacles their patients face on a day-to-day basis, what policies are implemented within their own healthcare system that maybe they can change a little bit to help them out. And then we also have these clinical conversation programs, which includes a specialist and a PCP. So for a diabetes program, it's going to, have a primary care physician there and, also an endocrinologist there as well. And with the Affordable Care Act, it really changed to that preventative care, and your primary care physician sort of becomes your gatekeeper for all of your care. And your PCP should be aware of all of what you're doing. Referrals should come from your PCP, so they're kind of in the loop there, but sometimes they always don't happen. So it's important for them to communicate with each other, really understand how one treats one disease and the other is going to, support that treatment. And then lastly, we have our innovative technology. And of course, we're always going to use Bloom's taxonomy for, defining our learning objectives and hitting our parameters and those guidelines for adult learning. But introducing new ways of technology for delivery is huge. And that's how, adults, and that's how things click for us. So we've done a lot of 3D work. We've done the game show a few years ago, and we also done VR, virtual reality. And this one I love because I was actually just at AVAHO conference, which is the Association for VA Hematology and Oncology. And we were displaying some of our virtual reality content in cutaneous squamous cell carcinoma. So this video really dives into the molecular components. It takes you right to the cells, and it's great. And the clinicians were actually coming up to me, taking stacks of our glasses, the glasses they put on and what attaches to your phone and the QR codes. They're like, can I show this to my patients? And I'm like, sure. So they want to show this to their patients because it's going to explain a little bit better, with these images more so than words, why, if they have to have Mohs surgery, why this has to go so deep when, it's really just on the surface. Like, why do you have to go, an inch in there? Like, why does this hole have to be so big? So it gives them a little bit more understanding and perspective of what's going on, which is incredible.
So Halini, I'm gonna maybe jump in here for one quick second, and say thank you you've educated me in the past week on health inequities and social determinants of health and public health and what it really means. And as I'm sitting here reflecting, I'm in Orlando at a company meeting. We've been doing this, and we should all be very proud of it. This is what we do as CME professionals. And as commercial supporters, we have been at the forefront by supporting these types of programs, whether it's with MLG or any other provider, because without it, these types of opportunities might not be out there for people, right? It can be very static about, safety and efficacy of the drugs or the clinical trials. The programs we are supporting is so much deeper than that, right? Screening and referral, quality of care, looking at if somebody is a rural, clinician, how are they helping their patients? So I want people to take away, when I was first, talking with you all about this, I was like, oh my gosh, what am I going to add? And I was like, feel proud what we're doing here as an industry, because we are addressing public health, whether we realize it or not. So.
Thank you. Absolutely. We certainly are. And this is what I mean. Like now that we can bring more awareness to it, we can bring more intent behind what we do and tie it all together and be a little bit better. And even with when I saw these clinicians wanting to take the technology that we created, of course, it was created for the clinicians, and that language isn't going to be suitable for patients, but we are 100% able, and we can do translations and, voiceovers and make it more patient friendly. So, we're adaptable here, and there's always going to be room for creativity for us to do that. And one of the definitions I think I've passed by it. One of my favorite definitions of public health is defined by someone from Yale in 1920. And he defined public health as an art and a science. And it really is that. So there's always room for creativity. There's always room for innovation. And I know even from a clinical standpoint, and Nicole, I think you've always said it's the art of medicine.
It is. That's a staple of medicine. It's the art and the science of medicine, but medicine truly is an art. And that's where public health and medicine come together, especially clinically. And for context for the audience, I am an osteopathic physician trained in internal medicine. So I can truly speak to the clinical aspect of things. And Helene, I actually want to hinge off a couple of things that you've just said as we transition into the case study for the model of how CME is intertwined with public health. And I actually read an article last night about clinicians and health literacy. And it's important to remember that gaps in health literacy are not just on the patient side, they can be on the clinician side as well, which was just, it's a stark statement, but when you read it, it makes total sense. So understanding where the gaps are in knowledge, both for the patient and for the clinician, can help bring forward improvements and progress in the public health measures that you just mentioned. Looking at the ways, leveraging that innovative technology, the different types of conversations. You said the primary care was the gatekeeper, and that is truly a very appropriate statement. You have multidisciplinary care. Not everybody participates in multidisciplinary care, but they should. That is the model going forward. And getting those conversations together where you can look at different perspectives between an ophthalmologist, which is the case that we'll be looking at, as well as primary care, or between two different specialties and what their roles are and how they can meet together for the betterment of the patient, is truly wonderful, because sometimes those conversations don't happen. And to be truthful, they probably likely don't happen. It's not sometimes, it's probably more likely. So Derek, I'm going to ask you to switch over to the next slide, please. So the next slide is, what does it look like for social determinants of health and health disparities from a clinical perspective? And taking in case in point that case study on ophthalmology and diabetic retinopathy, which is what we'll be discussing. Let's take a look here at a few things that could affect this patient. So you have a patient that needs to see an eye care provider. What could be their barriers? They could have a lack of transportation, or maybe transportation's too costly. If they don't have a car, they have to take a bus or a train. What if they are in a rural area or at least 60 minutes away from their provider? That could be in an urban case too, where they can't walk there, they don't have public transportation, or public transportation is too costly. Maybe they have childcare issues and they can't get there. So you have these gaps between the patient and the provider. Now, if you look at it from a flip perspective, you could also have a provider desert where there's plenty of providers in your neighborhood. Unfortunately, your insurance doesn't cover it. So there's lots of factors that clinicians should be aware of that could affect that patient even getting to them. There's also issues with there's a disproportionate effect of disease on specific populations. So there's populations that could be at higher risk for certain diseases, a higher risk of morbidity or mortality, ones that have greater consequences, and even ones that are known just by epidemiology and research from public health that shows that they have a harder time getting to the eye care provider, getting disease treatment. They're recognized later, and this could all end up in poorly controlled disease and effect on their visual quality of life, and even blindness later in life. So these are all important things to consider upfront, to make sure you're getting to that patient as early as you can so they can get the treatment that they need in a timely manner and save their vision. Derek, next slide, please. So I'd like to introduce to you Vision Relief, and this is a community care platform that is a wonderful case study on the positive impact of continuing education on vision health, in particular for diabetic retinopathy. And diabetic retinopathy, as I'm sure everyone on this panel can speak to, is a huge public health issue. Diabetes is a huge issue in the population, not only in America, but also globally. And it's only increasing. More people with prediabetes, now more people with diabetes. And those projected numbers only continue to increase in the tens to even greater of millions each year and each 5 years. So looking at ways we can impact is educating both the clinician and the patient. Patients need to have some equity and some advocacy in their health. They need to have a way to feel empowered in taking control of their health. So give them the education. And you can leverage this with innovative technology. And on the platform, we have tailored education tools that are for patients and clinicians of various disciplines. It's not just for ophthalmology. We have primary care, endocrinology, retina specialists, ophthalmologists, optometrists. Every role has something different to offer and different educational needs. So we try to address them all. We use multi-sensory learning modalities to help accommodate different learning styles. Some people are visual, some people are audio, some people like it both. Some people like to read text, some people like to learn from a video. There's pictorials, infographic summaries to help you understand a research article or a trial article that maybe is just a little overwhelming, but you can really pull out the nuggets of information that are important to apply to clinical practice. And that's the goal, making changes in clinical practice to benefit the patient. Next slide, please. So how do you increase health literacy and close those healthcare gaps? Like I just said, you want to educate clinicians and patients to increase the awareness of, in this case, retinopathy and its threat to vision. So if you have that better understanding of retinopathy, what's that going to do to the primary care physician? They're going to promote referrals for screening, which is going to result in that timeliness of treatment and intervention and even adherence to treatment. If you can talk to your patient about how it's important to continue with your treatment, that's only going to improve their visual outcomes in the future. We want to empower those patients, like I said before, to actively participate. And again, this ultimately leads to better visual outcomes in vision-related quality of life. It follows guidelines of treatment, which you see, that's that screenshot you see right there. You're empowering patients to get better treatment and educating those clinicians to actually follow guideline-based treatments so that they're getting scientific basis and betterment of care. Next slide, please. So in looking at the educational offerings that we have, this actually encompasses a variety of learners over a multitude of specialties from ophthalmology, primary care, endocrinology, nursing, pharmacy, managed care. They're all included in here. And you can see over the last few years, we have overall improvements, vast improvements in ability to utilize screening tools to look for eye disorders, applying knowledges of what happens in the eye that is bad to get them to treatment. So they're recognizing what the pathology is, they understand the root causes better, and they're getting them where they need to be and applying it to treatment choices. And they're utilizing clinical data, again, that guideline-based treatment to get them the best care that they can get, treatments that we know work, treatments that have been proven to work. They're now following guideline-based care. Next slide, please. Okay, so how will education result in better vision care? Now, looking at two recent conferences that we've had targeting the primary care audience, but also endocrinology, cardiology, and other internal medicine-like specialties that deal with diabetes that are not ophthalmology related. We have a variety of different disciplines, even across the two different conferences. They looked at three different learning objectives: understanding early detection and referral, identifying why patients could benefit from early initiation of therapy, and the importance of multidisciplinary management. As you can see, there are significant gaps in knowledge when they first took that test. But after the education, and this education was a 10-minute virtual reality animation, they had significant gains in what they took away in understanding that they need to be referred early. Treatment early is better for their vision, and multidisciplinary care is essential in getting the best care for those patients. Next slide, please. So as a result of those learning objectives and that animation from those two conferences, this was an evaluation that was given to the learners to ask them whether or not they were going to incorporate changes that would have any impact on patient care. And the vast majority said that they were more likely to refer based on guidelines. They were likely to optimize comorbid systemic risk factors, which could be hypertension, cholesterol, of course, your blood sugar. They were more likely to discuss the importance of early identification and assessment to help encourage those patients to keep going on with treatment and getting to the eye doctor, being adherent. And of course, to incorporate multidisciplinary care, they're going to go talk to that ophthalmologist in the eye care team, which is essential. And again, helping maintain that patient's quality of vision. Next slide, please. So how do you break down those barriers to care? Clinicians may be unaware of what their patients are encountering in terms of barriers to get to them. Could be social determinants of health, language, literacy, culture. You know, there's cultural barriers. Some cultures try to care for everything at home. They don't take patients in until it's too late and there's not much to do. Language, you could be giving patients handouts and things in their own native language using a language line. Again, health literacy, it's on both sides of the aisle. Getting there, we talked about transportation, fear and trust. You'll see a picture there about living with diabetic retinopathy. Hearing about a treatment or their disease condition from another patient, we can really help a patient understand and get over that fear, help build that trust because they're hearing it from someone else who's going through that same experience. And of course, demographic health disparities. You need to be able to identify and recognize who's at risk so you can target those patients and get them the care they need. Education is the key. Next slide, please. So again, looking at diversity, equity, and inclusion, you can see here that there's a broad spectrum of learners across specialties, and that multisensory education helps enforce and reinforce key concepts, enhancing retention and hopefully implementation into practice. So you have these tools, you've got whiteboards, you've got posters, things they can use as point of care tools to teach their patients while they're in the office. All these are facilitators and can break down barriers to health literacy, education, and better patient outcomes. Next slide, please. So how do we translate these educational gains into better patient care? As you can see, as looking at this case study of the education that is given, there is a gap in baseline understanding and significant gains even across concepts in diversity, equity, and inclusion and how they impact ocular disease prevalence. So you've got retina specialists, ophthalmologists, optometrists, primary care. They're all seeing the value in understanding who is at risk, factors that contribute to disparities, understanding that you need a better, more diverse workforce, and why it's important to have more diversity in clinical trials. This has ramifications directly on patient care. Understanding patients and having more diverse clinical trials means that you're going to have better data on whether or not a treatment affects better or worse a specific population. If you have a more diverse workforce, you're going to have patients that feel more comfortable, just as Helene spoke to, in speaking to a clinician that is of their background that they feel they can relate to. These are all ways to expand knowledge and eventually filter in directly into patient care. And so next slide, please, Derek. How do we get there? Advancing patient care and continuing education go hand in hand. We can improve outcomes and reduce disparities by the connection between public health and CME. Helene, can you speak more to this?
Helene, you're on mute. And if you could just
Yes, I
give a quick note to it, and then I'm going to turn it to questions so that we have some time.
Absolutely. So as we can see the shift in healthcare rapidly changing. It's going from a proactive to a more preventative approach, and education for providers should absolutely follow suit. We have to operate on a unified front. Otherwise, the education that we deliver is going to be different from what the clinicians see. And of course, I have another theory, another public health model to introduce to you, and that's the diffusion of innovation. And that essentially is going to speak to, how we give something, when we introduce something new, how that's going to gain momentum. And that's going to gain momentum by, us as industry leaders. We are on the front lines here. And if we're all going to all operate together with a powerful and impactful influence here, introducing this to our industry should be seamless.
Thank you, Helene. I think that's a great way to look at it. And I think the case study Nicole shared really shows how we are already doing this in many ways. And I think, to your point, Helene, we could speak to it more to really highlight CME's role in public health. But I wanted to save some few minutes for questions, particularly to you, Sam. There's a lot of interest in your view of, in general, like how much do you consider public health goals when you are looking at proposals or creating RFPs? And in particular, there's a couple questions along those lines. One says, is the impact of public health considered for all grant submissions, or more so only when it comes to specific CGAs and RFPs?
Great. No, thanks, Lauren. And I was sitting here, I saw that question come through, and public health should be addressed in every single program that we're supporting. And it does. I feel like people are sitting here going, oh my gosh, I have to write a public health objective. You don't. It's how you incorporate it into your pre and post test, right? It's how you look at the clinical data. Helene had shared with me that I learned, that's not my area, but that more white women are diagnosed with breast cancer, yet African American women die from it more often. And that happens to do perhaps with the density of their breasts and the tests that they're not taking. So how can you guys as C providers look at those differences and incorporate that into your program so it's not just the same old, right? So you're including and addressing that public health. So, almost I want to say shame on us if we have to have a specific CGA or RFP to address public health, because it really should be part of everything that we're supporting.
It actually,
And oh, I was just going to also, and I thought, so what Nicole showed and as a case study, that does require significant investment, right? That is not a small program by any means. But I want to challenge those people that might not be able to make that type of significant investment to still support other types of programming. It can be smaller. It doesn't have to be the Rolls Royce of education, right? We still need, I'm a big analogy person, we still need Toyota Corollas. No offense to anybody that drives a Toyota Corolla. I started driving a Toyota Corolla. So we need it all. How do you how do you incorporate that in, right? And you're doing it, right? Even with your pre-post. I keep going back to that because I was like, man, we're doing that already. You guys are doing that already. And it's the so what. So what can you guys bring from your programming back to us so that we can bring it internally? And I'm so proud to say, like, we're always at the forefront. We're at those innovators. We're at that 2% internally with our teams where we're so ahead of everybody, and we're kind of going, we've been doing that and you're just talking about it now, really? So how can we help even our internal colleagues understand? And now that's kind of on my note to self, how are they including public health in their initiatives that they're doing?
Sam, I'd like to add for what you just said in that you don't need a specific learning objective, but it's already built in. You're right. You don't need a specific public health learning objective, but you need to shift your thinking in what does this constitute? If you think about the case study you just gave in the white women versus African-American women and who's dying versus who's diagnosed, you could summarize that up into who's at risk. And if you look at who's at risk and really pull it apart, you're looking at who might have disparities and who you need to recognize that needs more attention or who might not be getting screening. So it's already built in. You just need to recognize it.
Yep. And, even if you are just looking at clinical efficacy and safety, there's diversity in clinical trials to consider. There's many ways to incorporate this within a program, regardless of your objectives. We did have another question on the partnerships. We had mentioned that we work with OMH as one of our examples and what the experience is like working with those groups. We've had a fantastic experience with them. We've done several programs also with AHRQ, reviewing our shared decision-making case examples. I would say the hardest part is just finding the right avenue to get in and the right person to address. It takes some research and digging to, find the working group within these massive organizations that address the issue you're trying to focus on. But once you do, there's also a couple other loops you have to jump through, such as, there's some red tape as to, signing things, accepting that, they're okay to work with us, where the support is coming from. And once you get through all of that, then it's a sustained partnership. Then you have your 2 or 3 people that you're calling to review your content, sharing your cases with, and it works pretty seamlessly.
And Lauren, I see another question about how you incorporate into programming that is mostly about clinical data. And I can say from an ophthalmology programming perspective, it's a lot of clinical data, especially when you're dealing with retina specialists. So I can appreciate that question. And I think just based on experience of how we approach it, looking at who is at risk again, like I mentioned before, but also the disease itself. When you're breaking down what the disease is and you're looking at the epidemiology, the incidence, prevalence, you're going to start teasing out that kind of information, and you can really take a quick but deep dive into who's at risk, who might have more risk for being affected, who might be more at risk for not getting treatment, and put that all up front before you get into treatment so that you're addressing it, you're highlighting it to the clinicians who need to know where they should be putting their focus on, and then getting into the nitty-gritty about how the clinical data is going to impact patient care.
Thank you, Nicole.
Mm-hmm.
We had one more question if we want to hit that real quick. I find this to be a very interesting perspective. How could we message this more to show the value of CME in addressing public health concerns? Sometimes we get caught in a bubble and don't think more broadly of our role. That's a great point. I think like this, what forums like CME Palooza are helpful in drawing these kind of things out. And I think, Helene's point at the end was really, how do we do this? And I think continuing that conversation, we don't necessarily have an answer to that beyond continuing to fold these into our programming across therapeutic areas. As Helene said, public health goals are therapeutic specific. So we can, looking at Healthy People 2030 and what those goals are for each therapeutic area and folding that into our programming, and then talking about it, highlighting it, not only in internal forums, but at associations. Nicole's going to be at ACOI in a couple of weeks talking about vision relief, doing those kind of things and sharing what we do for public health to a wider HCP audience, I think is a key there.
And to parlay off of that, Lauren, I absolutely agree with that. And from a clinician's perspective, I would say show the clinician how they can make a difference. Show them where they can make an impact and how they can do that. Give them the tools. And we want to help people. That's what we were trained to do. That's why we got into medicine. That's our calling. So if you can give them that empowerment by the tools and the knowledge, they'll do it.
And Derek, one last thing, I guess, because I didn't speak too much as a commercial supporter. I know everybody's very interested in hearing what we have to say. It's all on the outcomes, folks, right? And what you provide back to us, that will help our internal cause too. And as I was even thinking here, like ask, do you think there is a disparities of care between how African Americans and diabetes are treated versus Caucasians, right? You can get to those little nuances and make people start to think even before you have the educational program. And then when you're looking at your real world data, again, not all programs can have real world data tied to it. It's expensive at some points, breaking down and looking at those different groups as well, right? Not just overall looking at the clinician, but looking at your patient subpopulations as well. So.
That's great. Thank you all for a fantastic session to get our day started. Really appreciate all your perspectives. A few quick housekeeping slides from me as we wrap this up. Just a reminder, if you have a moment and can take our survey at the end of the day, it's right on our live tab. We do appreciate all your feedback and use that as we develop subsequent CME Paloozas. We do have a cool new event called our CME Palooza Scavenger Hunt for all of you to participate in. Just go to Broadcast Beat Studios, who's our sponsor of the event. Click on their link. It's on our homepage. Look for the CME Palooza logo. There are prizes. You have to click on the logo and you'll find out what happens. Very dramatic. And then lastly, to view the next session, there's a link right on the live page. Next session coming up is Gamification in CME, Balancing Entertainment and Education. That'll start promptly at 10 a.m. Eastern Time. Reminder that the archive of this session will be available immediately after we end. And for all of our sessions as well are available right after they conclude. A big thank you to Array for sponsoring the archive this time. So thank you to all the panel. Appreciate it. Lauren, thanks for moderating. And of course, MLG for sponsoring this session. And I will see you next at 11 a.m. Thanks, everyone.
Thank you, Derek.
Bye.
Thank you.